bit about mental health. Here, I'll start over again here. Oh, how come it's not? There we go. Sorry, we'll start over again. So today, our community of practice is going to be an attempt at more practical application of the NRF specifically, but in the context of mental health, how we look at a case of a feeding challenge in a holistic way and looking at parts to whole. And I'm hoping that this will kind of give a more practical, user-friendly way of looking at an feeding situation. And so I am going to be organizing this case around the neurorelational framework as a way to look at 3 steps to approach a case. The case is fictitious today. I thought that might be the best way to demonstrate. And then I'm really hoping that some of you will be inspired to feel that you can present a real case, and we'll do a live kind of review and organize it in this way. And I'm also hoping today that we have discussion back and forth, talking about therapeutic strategies and how we work collaboratively together to help kids with these kinds of challenges. So again, this is a made-up situation, and I'm going to use these 3 steps of the neurorelational framework to organize the case. The first step is understanding stress responses, stress recovery, toxic stress patterns in the autonomic nervous system, and we'll also be talking about sleep, kind of as a foundational health, underpinning all the rest. We're going to talk about the importance of relationships and the dynamics of the relationship for this fictitious case in the trunk of our tree. And then what I'm going to demonstrate is the way to organize all the data from multiple disciplines in the branches of the tree, where we're going to organize the information in 4 brain subnetworks. Okay, so step 1 for this child. So we're going to start with observations of a feeding situation. So at this point, a clinician of whatever discipline is involved in this case, so we'll say it's me in this situation because it's my pretend little person who is called Amy, by the way, who is a 4-year-old girl. So what are we observing at mealtimes? We'll start there. So for this child, when she is at the table, she is looking around, she has darting eyes, she's vigilant as to what's happening at the table and around her with her family members and the kitchen. She's got a furrowed brow, she's got a bit of lip compression where she's got that tension in the bottom half of her face. And she's got rigid posture. So that rigidity or tension is in her other big muscles sitting in the chair. And what do we see from mom? Well, mom has frequent breaks in eye contact with the child. So reciprocity back and forth is not optimal here of that serve and return. She also has a furrowed brow and looks worried. She is talking to the child in a pleading, high-pitched voice about the food and mealtime, of what's going to happen, what's going to be presented to the child. And she has jerky, fast movements. This is what we're observing. So mom's dashing around the kitchen. She is not in a calm, alert processing state. So these are just very simple observations. We're looking at what we can call biobehavioral markers. So we're looking at different markers of stress reactivity in both the parent and the child to understand whether they are having an adaptive stress response to this feeding situation, or are they in a calm, alert state, or are we worried that this is not necessarily an adaptive stress response to this situation? And we know that when parents and kids are in a calm, alert processing state at mealtime, then we're more likely to have success with feeding and eating. So we could use this framework and showing the mom and dad information about the autonomic nervous system and stress responses and explain to them what they may see in their own behavior or each other's behavior, indicating a stress response, and what they can look for in the child. The point of this is that we're supporting the parent to be reflective and observing their child's behavior from a different perspective, not maybe interpreting this child's behavior as being a refusal or being obstinate or stubborn or rigid, avoidant. We use different behavioral words sometimes to describe what's happening to the child in the chair at the table who may not be participating in the mealtime. And so the idea here is to try and shift the parent's perspective of looking at this child as being stressed, identifying their own stress signs, and then supporting the parent to self-regulate so that they can then co-regulate the child in this situation. So I've described this before. I'm just going to quickly give you a quick overview because then we're going to look at these states in this particular dyad. So the red zone is where the gas pedal goes on, or sympathetic reactivity in the autonomic nervous system, and it can be positively or negatively, affectively or emotionally valenced. The break is when we have the parasympathetic activation and we have a shutdown and withdrawal and disengagement, slowing down. And the combo zone is where we have co-activation of parasympathetic and sympathetic reactivity. And this is where we get more nervous, anxious, jittery behaviors. And so I would suggest that from my description, and I've made it this way, is that both mom and child are in this combo zone and they are feeling anxious emotions. So I've mentioned this before, as we have these awake states indicators, we have this chart, which breaks it down for us as to what to look for eyes, face, voice, body posture, gestures, rate and rhythm of movement, and breathing, so that we can kind of be detectives and look at the behavior. So us as external observers trying to be objective, look at what's happening for this dyad or family, if there's more than one family member at the table that we're observing. If families video a feeding situation, that we can watch it from this lens. It's just one way to observe. And there are many other tools, and we mentioned some of them in the last session, to how to observe parent-child interaction and to observe for different cues and markers of behavior, looking at things from a different perspective, not just is the child being compliant with a mealtime. So we're describing these as biobehavioral markers because they're actually indication of what is happening in this child's nervous system. And another way that we can dive deeper is to ask questions and observe for these markers of involuntary visceral cues. So the NCAST tool that has been available for very decades now, I can say, is a tool from Washington University, where they another way to observe parent-child interaction around feeding really describes some of these kind of these visceral cues that young children show when they're stressed. And that system talks about engagement or disengagement cues, which map out quite well, again, to those biobehavior markers I just described, those awake states behaviors, as well as some of these visceral cues, these interoceptive cues of what's going on with regard to stress reactivity. And so for this mom, as she's dashing about the kitchen, she's got a furrowed brow, she's got this high-pitched voice. She may also be feeling in her gut that she's got butterflies, or sometimes she's actually got her guts churning, where she's, feeling in her lower bowel that it's churning, or she may feel some heartburn even as she's experiencing these meal times as being stressful. And we may see some of that in the child as well. We may see some of these more subtle to moderate cues. And we've all seen situations where kids are stressed and they're vomiting in meal times. I have kids come to my office and they have a bowel movement, that they have an accident of one kind or another due to stress. So this is something else we can educate parents about and ourselves to be supporting our observation of what's happening with regards to stress. So let's go to our case of Amy and her mom and dad. So when we are not at meal times, Amy is in the green zone. She's calm, alert, she's having fun, she's engaged with activities. And at meal times, we see those biobehavioral markers of anxiety. And sometimes we also see this disengagement where she kind of is staring off and slowing down, non-responsive at times. So she's maybe in that blue zone. At other times during the day, she can be a busy gal, and I'm going to describe to you some sensory seeking behaviors where she can be, we'll use the generic word, a bit hyper. So this is a way of, again, we can get at what we call a subjective pie through interviewing parents to get a kind of sense of how an average day is. And we can ask about an average day, an average evening, an average weekend. We can ask for the worst day, a more challenging day, a best day, and just even gathering subjective data once we've educated parents about these different states of arousal. It's a good way, again, to reframe the parents' understanding of their child's behavior and get them to be observing and more reflective. So this is, so, and clearly there's a good chunk of the day where Amy's in a calm alert state, as is her mom. And so you can kind of see that mother and daughter are kind of matching with their stress reactivity. And mom's got some extra combo zone because she worries around before meals and after meals and before she goes to bed. Her mind is focused on meal times. And I'm sure many of you have chatted with moms over the years and supported them who are anxious and really concerned about their kids who have feeding and eating challenges, where the mother has trouble feeding and the child has trouble eating. And it can get to be a preoccupation, and that the parent is in this state of arousal a chunk of the day, worrying about food. And then if we look here at dad's pie, dad is less concerned here, and he describes that he is a busy guy. He likes to be physically active. He's also kind of sensory seeking, and he so that's kind of his go-to stress response. If there's, he may get busy when there's stress in his day, but it's positively balanced for him. So so one would look at this pie and say this is adaptive stress responses and stress recovery for this dad, and a bit less adaptive for mom and Amy. So I'm going to talk to you in a bit when we go through step 3. We're going to talk about sleep. But I just wanted to put in here that sleep affects our capacity to have adaptive wake states. So when we're well rested with good quality and quantity of sleep, we can manage these states of arousal and self-regulate and co-regulate our kids or other adults who need co-regulation. And if we have poor sleep, then we're more likely to have more stress reactivity and possibly toxic stress patterns. And I'm just going to go back. So this dyad, the 3 people in this family, I would say, are not necessarily in toxic stress, because although there is stress around we may consider that there's too frequent, too quick, and possibly too intense stress responses around the meal times, but it's not the whole day. And the child has some separation anxiety around transition, so that may be a toxic stress pattern. But again, I'm going to describe to you that not necessarily of the severity where we'd say it's pervasive. And I'll just say for this little one that although she is anxious during the meal, the meal is lasting 15 minutes. So our thought is that if stress responses last more than 20 minutes, that's too long to take to recover. Maybe mom has too long to recover for her combo zone stress reactivity. And all 3 members of this family do have recovery to the green zone. So for our case here, we're going to monitor for possible toxic stress patterns, but we're not alarmed at this point. Okay, so we've assessed for adaptive stress recovery and stress responses and whether there's toxic stress patterns for these family members. We have a sense of what's going on in the nervous system. And now we're going to look at the qualities of engagement. So what's happening with the back and forth reciprocity for this? We'll focus on mom and daughter at this point. I'll tell you a little bit about mom and our child and dad as well. So we use the trunk of the tree of this NRF to guide our conversations with families about this reciprocity and this back and forth and serve and return that we know is so important for social emotional development for young children. And so let's just focus specifically on the eating situation for this dyad, because I'm going to tell you outside of eating, this back and forth goes well. And this 4-year-old has the capacity for nonverbal engagement that is age appropriate, and also is having pretend play and sharing of emotional themes and talks about her feelings, and is starting to have some emotional problem solving back and forth with her mom and dad as well. However, when it's mealtime, we have challenges here, especially here at the bottom, in that it is hard for mom and daughter, we'll take that diet especially, to be calm together at mealtime. So those nonverbal cues that I described, those biobehavioral markers, are present, that they're both in this combo zone at mealtimes. And mom is having a hard time self-regulating, so calming herself, so she can be a calm, available presence for her daughter, and so that she can provide this co-regulation and help Amy get calm at mealtimes. And so we have a bit of a vicious cycle the other. And so what we would be looking for, if it was going well, is that there would be eye contact between the two of them, that there would be calming touch, if that is calming, that the voice of the mom would not be in that high-pitched zone, but would be, again, a regular pace, calm, soft voice that's reassuring. And that we have the right setup of other sensations to share that are pleasant. That's our goal. And again, with kids, I'm getting to what the feeding challenge is, it's tough. But the idea here is that we have positive engagement and sharing of joy, positive emotions being shared during a mealtime. And that we would then see these back and forth for this child, because she's 4, these back and forth chatting and sending and reading cues appropriately, and not necessarily talking about what's going on at the table, but being able to share ideas and chat about other things. That's what we would be looking for. And so I can tell you for this dyad, there are concerns here that this is not happening when we observe what's going on at mealtime. So I mentioned that mom is having challenges self-regulating. So she is the co-regulating other, the cylinder around the child, which is represented by the cone. The child has immature capacity for self-regulation, because that's just development, and is requiring the adults to be co-regulators, and especially at mealtimes, because this is stressful for this child. So with mom not being able to self-regulate because she's anxious, the child is having trouble self-regulating. So we'll just talk about just briefly this. We use this tool, or this metaphor of the oxygen mask, to help parents understand this concept. And we use that, I use that cone and cylinder, as do my colleagues, to try and explain this trajectory of self-regulation development to the parents. The idea is to help the parent reflect and understand that, you know, what are their self-regulation tools? And again, we're going to talk about this some more. But this metaphor can be helpful to introduce the topic of why it's so important for adults to read their cues and have ways to get themselves calm in whatever parenting situation they're in. Okay, so now we're going to go to step 3, and this is where the pedal hits the metal, and we're going to dive deep into understanding this case. So just before we start, I'm just going to remind you from last time that we're going to organize all the data into 4 brain subsystems. And I'm going to remind you we're doing this because skill begets skill. All brain networks, subnetworks are important, and brains are built from the bottom up. That's the principle that we're using here. And I'll reiterate that these 4 brain network subsystems are made up. There are human creation to describe and organize data. We know that the brain is way more complex than this, but again, there's lots of neuroscience to support this way of thinking about organizing clinical data. And the other reason we're doing this is you can't focus on one area of development or challenge without paying equal attention to other capacities or challenges. So we need to look holistically at strengths and challenges. So is this only a mental health approach? No, it's a whole brain approach. And we're going to do that by using this trigger and toolkit chart. So I use this with agencies in the community where we're talking about complex kids with a variety of different challenges. Today, we're going to do it. We're going to go through this brain system by brain system to understand how do we understand this whole child's challenges, and how do we organize an effective treatment plan. And then just another little bit of background information. This framework that I'm describing to you is a map. It holds all clinical models, theories, and evidence-based treatments. So when I'm talking to you and when we're going through this, I'm hoping this is now I'm cueing you. This is the engagement part of our afternoon. If I've done my best to give examples of evidence-based interventions, clinical models. Please chime in and tell me what ones I've forgotten. The NRF holds all of our subspecialties and knowledge, and it helps us assess neurodevelopmental properties of the evidence-based treatments we know, and it helps us shift from the individual to the systems of care and the helpers, who's in the system who can help, and it holds diagnoses as well as developmental domains. So that's why we're doing it. This framework is a container, and this is how I think and organize cases coming from my system of care. Okay, so we're going to start at the bottom and work our way up from the body regulation brain network to sensory to relevance, our emotion, memories, meaning-making brain network to the executive system, which holds motor. So if we look on the left-hand side of this little gal's challenges, Amy, let's talk about her sleep. So she does have sleep onset challenges. It takes her a while to fall asleep. She wakes up in the night a few times a night, and she is restless. And she's in the night, she's looking for her parents to help her get calm and reorganize back to sleep. So for that challenge, again, I'll go through the list of all the challenges, and then we'll talk about the strategies. And then that's when I'm going to pause and ask if anyone wants to join in with some more strategies or tell me what I've missed. So she does have some sleep challenges, which again, I've alluded to that if there are sleep challenges, that may set up her up for more difficulty with her self-regulation of her stress response system. This little gal, so the feeding disorder is avoidant restrictive food intake disorder, or ARFID, and her symptoms that I'm going to make note of are poor weight gain, and she does lose weight when she gets sick, and she has very poor appetite and interest in food. So she's really got, again, she meets criteria. She has not got a good variety of food intake, and she's got poor volume, and it's just really hard to get her engaged. And no surprise that she has iron deficiency, and no surprise that she has got constipation. Sometimes we don't necessarily ask or keep track of this, but important to keep track of it. So I see these 4 physical health challenges, or the 3 physical health challenges that go with ARFID very, very commonly. And in this regulation system, we document the stress responses and whether or not, I mean, I've said here toxic stress patterns 1, 2, and 3, and I should have put a question mark beside those because we're going to track those. So on the what to do side in this brain network, we would address the sleep challenges. So, again, typical where we start is sleep hygiene. So some of these are across disciplines. So I'm talking about mental health and feeding. Mental health practitioners talk about sleep hygiene. Physicians talk about sleep hygiene. OTs talk about sleep hygiene. And probably many other disciplines talk about sleep hygiene too, because it is kind of, I think, personally, I feel that it could be universal. I'm coaching teaching assistants and teachers to address this topic with parents as well, if they feel comfortable, or at least introduce the topic of sleep. And then we can talk about nutrition as well being an important factor, that maybe, some of the night awakenings could be because this kid's hungry. It's possible. It could be because this kid has restless legs and she's got iron deficiency. So we need to supplement with iron. But then when we supplement with iron, we can make the constipation worse. So then we need to address that and monitor that carefully, because if kids are constipated, then appetite goes down, intake goes down. Sometimes I see kids with ARFID who also aren't getting adequate hydration. They're very picky with what the liquids are that are going in as well, which of course affects overall health. And we know poor hydration during the day doesn't help stress reactivity either of our self-regulation. And we might do some education about, as I said, to educate the parents about these bottom-up needs of their child, and that these bottom-up needs need to be met to support the treatment of the ARFID. So I'm putting ARFID in the body regulation brain network. But again, you're going to see that it's addressed in the other brain networks as well. And I've tried to, in every brain network, talk about who are the disciplines that may be involved more primarily, although I've alluded to already for sleep hygiene that can cut across disciplines. So I'm saying physician and dietitian as two key players to support our bottom-up toolkits. So I'm going to pause there and just see if anyone wants to make a comment. I'm just going to stop share for a minute and just see if anyone wants to make a comment, give a clinical vignette, or any kind of input on what I've described so far as our bottom-up regulation body brain network so far for Amy. Does this resonate with some of you as clinicians as to a constellation that you have seen before of struggles? And do those strategies seem appropriate? I've got one thumb up. And I guess my other question is do those, again, the start of our strategies, our toolkits, sound appropriate as well? Yeah, so thumbs up, yes. So this is kind of bread and butter. Like, this is very common that we would see this. So, but for me as a psychiatrist, as a mental health provider, from the beginning of my career, I understood all this. I couldn't really describe why I was the child psychiatrist that was talking about poop. I pull up my, I'll just show you, I have my poop chart right here, handy, ready to go. OTs in Edmonton laugh at me when I pull it up. I actually told them yesterday that they all need to have it laminated. But why is mental health concerned about the body? Well, because it's the foundation. It's the foundation of mental health, is to have good physical health. Okay, so now I'm going to move on to the next brain network. We're going to go up and talk about sensory. Okay, so let's talk about what's going on for sensory for our little Amy. Amy has a severe speech delay. So speech in the NRF is in, we just decided to put it in the sensory brain network. We have a lovely explanation for this in the interactive manual. But the bottom line is to create speech, we require we require, understanding sound, producing sound, all the sensations in the oral motor system. Motor is in the executive system, but of course important for speech production as well. But that's the very quick overview of why. And just so you know, we consulted with speech and language pathologists and made sure we got that, the whole description as correct as we could. So severe speech delay we've documented here in the sensory brain network. Little Amy is overresponsive to sound, clothing on her skin, can't stand anything that's too rough or scratchy. And of course, she is sensitive to taste and texture of food, and some smells as well, but hard for her to describe that at 4. And I often wonder, I read a book on taste, on the sensation of taste, and learned more about how integrated smell and taste are. So we might have some of the OTs jump in on this one. But I really wonder for our little kids with ARFID, whether or not this is part of what's driving it, is that there's some atypicality in smell and taste that is contributing to this. And of course, our little ones can't describe that. They don't know what they don't know. So that's something we could potentially discuss. And then she, as I said before, she's got a bit of that positive red zone because she is sensory seeking of movement, vestibular and proprioceptive input. She's running, jumping, climbing. She's twirling herself a bit. She likes to swing. She likes to, crash into the couch and, climb under the cushions. And yeah, so, but not excessively, but, kind of a moderate level of sensory seeking. So that's just, again, overview of some ideas here for Amy. Sensory wise, we've looked at that, and she has had SLP consultation and assessment with regard to that speech sound delay, and she's getting treatment for that, which we'll talk about in the executive system. And she is working with an occupational therapist who is providing her with an SOS intervention. And we're supporting the family to understand to avoid food jags. We talk about try again foods. That was a phrase from one of my families. And the no thank you cup. I was calling it a spit cup for when we reject food, but lots of families didn't like that. It's a bit gross. So we're calling it the no thank you cup for now, for the try again foods. And that, that's an evidence-based intervention. And there are likely other, with regard to our supporting this little gal to try new things, there's probably a wealth of other ones that we can discuss here. And then we're also providing opportunities for movement in all directions, deep pressure and heavy work. This little gal, again, back to our concern about her sleep. In the sensory system, we have a few extra strategies. Providing her with this movement during the day will help with restlessness at night. And the sound machine at night might help because she's sensitive to sound, remember. And massaging legs in the evening, rhythmic movement, that may also help her settle to sleep in the evening. So you can see how we're tying in strategies from other brain networks for bottom-up regulation challenges. Okay, so any comments about sensory? Anyone want to jump in with any other comments or strategies at this point? I'll just stop share again in case anyone wants to come off camera or come on camera. Anyone have any comments about that? Does that seem pretty straightforward? Again, something that we would, I'm describing what I think are kind of typical we could use the word comorbid. And I think in mental health, I'm just going to be clear about this. I think in mental health, the sensory brain network is not necessarily holistically understood. I'm very lucky because in my career, I've been able to hang out with lots of OTs over the years who've explained this to me, and I've integrated it into my understanding of early childhood development and mental health. And again, you can't do one without the others. And so my anxious little kids that I see, very common that they are over-responsive to sensory stimuli. And this is from infancy, that they have sensory processing modulation differences that wire up with those combo zone or other stress responses. Very common. And it makes sense because neurons that fire together wire together. And so if we have differences in those two bottom-up brain networks, where we have more stress reactivity, we have sensory modulation processing challenges, then it should be no surprise then that the emotional valence, those emotional memories and the meaning that's made of those internal sensations and sensations coming in from the outside world are going to wire up to match. So let's, I don't see any comments coming in. And Crystal, you'll let me know if there's something in the chat. So let's look then at our relevance and meaning-making system. Hold on. Okay, there we go. So this little gal, Amy, has some separation anxiety symptoms. Again, I'm not going to call it a disorder just yet because, you know, sometimes when she's dropped off at her preschool, she's anxious, and sometimes when she goes to grandma's, she's anxious, but not necessarily all the time. But there is that separation anxiety and that struggle with some of those transitions. And as I've described, mom is anxious at meal times, and we see coaxing, pleading, offering distractions, dashing about, sometimes offering, you know, lots of food options. We have at the table also a younger sibling who's 18 months, and we're very grateful that this 18-month-old is just chowing down independently. So that's on the, I put it on the trigger side, but actually that one should have been on the recovery toolkit side because that's actually on the plus side. As I could have put this dad supportive, understands intervention plan, engages children in physical activities. That I should probably put on the toolkit side as well, because those are the pluses. So you'll forgive that error. So let's just look on the recovery toolkit. So we have an anxious kid and we have an anxious mom. I've already described that. So this is where we would put this label. So on the positive side, when both parents are home, this is a family that does have structure and routine and age-appropriate limits, and they have playtime, so that they, again, not around meals. We've got lots and lots of strengths. So we're looking for that. We're listening for that. Are there signs of health in relationships and family routines, parenting strategies and capacity outside of the eating situation? And then just this third bullet, there's more consistency with the eating strategies that are being suggested by the SLP and the OT and the dietitian who's involved on weekends when both parents are at home and they're less stressed after, you know, the whole day is gone in the evening. And so they are engaging in strategies like, you know, fun family mealtime preparation and shopping for food. And they are able to follow that division of responsibility of Evelyn Slatter or Satter more authentically. So things go better, you know, when there's less stress in the home and they're less tired at the end of the day for the parents. And this little one is going to preschool, and the parents are having some play dates and peer models of eating, which is a plus. And we've talked about the need to coach and support this family for both parents to really understand this need to co-regulate this child's emotions and stress responses at meal times, as well as times of separation. So how do we do that? Well, again, this may be the role of a mental health therapist on the team, although, again, lots of my OT colleagues have excellent skills with this. The idea of supporting anxiety tolerance strategies for mom and child, specifically for separation, a goodbye ritual. Do we have some social stories or breathing, muscle relaxation games before eating? What are other environmental strategies to support them to be relaxed at mealtime and at other times? And that can be the role of, again, as I said, mental health more specifically. So again, I'm going to stop share. Does anyone have comments or questions about that? If a child had more severe anxiety, then there could be a role for mental health and possibly even psychiatry to weigh in as to whether or not there needs to be treatment for anxiety, specifically in this case. Or if there was another specific mental health diagnosis, again, that would be, there may be an evidence-based treatment for that. So I debated as to whether to present a kid with ADHD, the kid who was hyper and wiggling and jumping out of the chair and crawling under the table and over the table, and and go there. We might be able to do that with a different case if someone wants to present one. But again, if there's a specific mental health diagnosis for a child at this age of 4 or else, then there would be another evidence-based intervention that we would add in, and we would note it there in this relevant brain system. So any comments or questions about that brain network? before I go to the top, and then we'll stop and discuss the whole thing? No, I'm not seeing anything. Okay. So let's go up to the executive system. Okay. So in this brain network, this little gal only has one real trigger or challenge that we're worried about, and she has oral motor delay, which is interesting because we've talked about in the sensory system that she has that speech delay. And so this is something to add into our whole understanding of this child's eating challenge, the ARFID, because yes, she does have ARFID, but she's delayed in speech, and we know there's some oral motor challenges there. So how is that contributing to the whole situation? So again, we're very grateful that we have SLP and OT who understand this combination of the sensory and the motor components for this child. On the plus side, the rest of motor fine and gross is age appropriate, as is her language, her pre-academic skills. And we have an additional practitioner of the teacher in the preschool who is aware of this child's challenges with eating and is supporting that peer modeling at school, and kind of a neutral environment for this child to observe and learn eating. And there may be, and sometimes in preschool, we can actually get, if there's, depending on the severity of challenge for a child, we may actually have some feeding intervention happening in that environment to support a child's eating. And then this idea of kind of the structure of meal times and routines, and where we would describe properties of food, avoiding judgment statements. This is where I put these kinds of interventions would fall into this executive or verbal top-down strategy. And social story as well, we could put it into the executive system because it requires language, but it's overlap with our emotion meaning making system as well. So more top-down verbal strategies for this little gal, and as she gets older, if she continues to have ARFID, more talking strategies to help her understand her challenge and help her understand the strategies that the adults are trying to provide. That would come later with more top-down capacity. And there may be some play-based strategies as well that we might use. So I've tried to show how to organize information about a case and present a little fictitious person to show you how we would look at challenges, developmental challenges, diagnoses, and interventions, and kind of look at the whole. We're looking at the parts, and we're looking at the whole of how we would organize the case. And in an ideal world, the disciplines involved would be intermittently sharing information and chatting and making sure that we're on the right page with our interventions, that we're reading the situation correctly, that we're providing the appropriate interventions, not overwhelming the family, that we've got a sequence to what we're doing. And maybe if there's folks on the team that have some transdisciplinary skills that we can, that they can cover off some of it so that we don't have so many people involved, and if we do have people involved, are we doing it in the right sequence, as I said? So the NRF organizes all of us into our areas of subspecialization and skill as well. So I'm going to stop share to see if there's any comments right off the top. And then I was thinking that we could have a bit of time in breakout rooms that it might encourage more discussion to talk about this. Just how was this case and what do you guys think of this approach? And I would be thrilled to meet with any one or bunch of you, if there's a team, to look at a real case and kind of go through the same thing and coach and support you to use this framework and then understand in more depth with a real case of how we would incorporate mental health, the mental health piece. So I'm going to just stop.
Hi, Dr. Hapshin, it's Crystal.
Yes.
Turn my camera back on here. I wondered if you could, to help people with the discussion, go back to the slide where it has the 4 discs piled on each other. I think that would be really nice. Okay. And Holly had a question, and Holly, I wonder if you just want to come off mute and ask it.
Okay, I'm gonna go back to that slide, or do you want me to just, I'll listen to Holly first and then I'll go back to that slide.
Okay, thanks.
Holly, what's your question?
We lost Holly. I'll just read out her question here. Holly has asked, can you speak a little more as to how she has ARFID and oral motor delays?
I'm
So,
off mute now too.
okay, you're off. Okay, yeah.
Yeah. I thought, like, I'm curious if her oral motor delays were like not at all impacting her eating and feeding until she was diagnosed with ARFID. That's curious to me.
Well, how do we know? So this to me is chicken and egg. See, I see this all the time, so that I see kids with speech delays that have eating challenges. And they're not mutually exclusive. So
Right.
that's why I
You're
presented
preaching to
it.
the choir about that for sure. So I just
Right.
am curious. Like I thought ARFID had to start like within the last 6 months. So I was curious about like no eating and
Oh,
feeding.
okay. So maybe I wasn't clear because again, this is a fictitious case.
Okay.
Oh, yeah, sorry. So let's just say that this little gal, from the time that she started talking, was not clear in her speech. So, and then, the SLPs gave her some time to get clear, and then they said, nope, she does meet criteria for speech delay. And then as they're following her and watching her speech sound production there and watching how she eats, they're noticing that she also has oral motor delay. So, and then she's got a restricted intake. ARFID is a very general diagnosis. It's about restricted avoidant food intake.
Oh,
Doesn't
what I've read
specify,
about
right?
ARFID,
Are they,
yeah, what
are
I
they, does anyone know, are they mutually exclusive? Like, no, I thought you can have both. Anyone want to weigh in on that?
Yeah, I just want to say I've always struggled with that actually with autistic kids because I always had felt that autism excluded a diagnosis of ARFID, and
Yeah,
the Glenrose feeding therapists have taught me that no, that's not actually true.
correct.
A lot of
Correct.
autistic children with ARFID, because I think, and now this is how I understand it as a physician and a GI doctor and not a psychologist or a psychiatrist, the anxiety is the very prominent thing that singles out the ARFID, right? We know there are a lot of autistic kids who don't want certain textures, don't want certain tastes, very sensory, but this high level of anxiety is the ARFID piece. They can have both.
It's interesting because in the criteria, it doesn't necessarily say that, right? That's our clinical experience. I agree with you, Justine. Absolutely. Because kids with ARFID are way more rigid. I see sometimes an overlap of ARFID and OCD, of severe rigid. And so and again, for all our diagnoses, there is a continuum. And this is why I keep chatting about this framework, because it holds, this complexity that yes, we can have kids with this and this. And we label things and we use diagnoses, which are helpful, absolutely. But then we need to actually look at function, and we need to look at all these parts and hold the whole child.
But I
So
guess I found, because if you can correct me, because I'm afraid I was scoping, so I missed the beginning of the presentation,
yeah,
but
no worries.
the criteria sort of allude to you shouldn't have another medical cause. And I think that's where I find the
Yes. So
confusion.
is an
There are a
oral
lot of,
motor delay a medical cause? See,
yeah,
I
and there,
interpret that as
okay.
the
And
child doesn't have a severe medical disorder. So I would say in the regulation brain system, the child doesn't have another severe medical reason that they
but
can't.
I'm not even sure that's, I'm not, I
How
think
clear
that's
is
where I
that?
find confusion, because there are a lot of children with complex medical illnesses that get ARFID, and there are a
Yeah.
lot of children, and the autism part, to me, autism is separate disease. So I always found that hard, but I've really learnt that now through the Glenrose, that they can really differentiate between the
Yes.
kids that just have a feeding problem and the kids that have autism, a feeding problem, and ARFID as well.
That's right. And it is on a continuum, because there's some, I mean, I've seen lots and lots of kids with autism over the last 35 years. And some of them, I mean, definitely have these, as you said, Justine, these sensory differences, and it does affect their eating, but it is not of a severity where we would say they have ARFID. And there are other kids that do. And they also would tick many boxes of different diagnoses in all the other brain systems. Yeah. Okay, so do we have time for breakout rooms? And you want me to put the hockey puck visual
People
backup.
want to go to
Do you guys
breakout?
want to go to breakout rooms, or do you
They
want to
can.
ask a few more questions? Anyone feel inclined to volunteer a case for another time? You can think on it. And if we had a case with more, with
I
a real case with mental health challenges specifically, we could dive a little deeper.
Mhm.
Tiffany, I'm not sure. I'm picking on Tiffany because she's the only person I can see on my list from the Glenrose, but we discussed a case where we argued about tube feeding, and I had said I would have referred to you actually and not for tube feeding. And I wondered, Tiffany, if you could go back to those providers and ask them if they might want to send that case, because, you know, obviously that mum was under a huge amount of stress and anxiety around the feeding as well. And I think it's a nice case because you could approach it from just addressing the feeding and tolerating some weight loss, or not accepting the burden on mum or any weight loss and tube feeding. And I always have some anxiety about that because those kids become tube dependent.
Yeah.
Tiffany, do you know the case we talked about Monday? Do you think you
Yes,
could
our
reach out to the
3-year-old.
team?
Yeah,
Yeah.
I can chat with
Yeah.
Victoria, our coordinator, about it, and then yeah, we could for sure
Yeah, and then
change
you
some
guys,
names and bring that
yeah,
info to the next one.
and then you guys could give me some info data ahead of time, and then I could start kind of plotting it out, and we could chat a little bit ahead of time, and then if you guys think that this way of organizing a case and talking about it would be helpful.
Yeah, I think
Yeah,
in this case
I
it
think
would
it'll be a
be.
good case because that child actually doesn't have a diagnosis of
Okay,
any, I think might have just been developmental delay. So I think it'll be a nice overview one. So we can definitely chat with our team and make it into a case study and send it over to Dr. Hapshin first to have a
Right.
quick peek see.
sure.
Yeah, I also feel like it highlights that if we had teams that had everybody we wanted, right, we
Yeah.
could approach these things in a different way.
Right.
But sometimes because we don't, and we don't have ready access to psychologists, I think these children end up with medical intervention. So I'd like to talk about it from that point of view.
Yeah, and then how do we, if we don't have someone within an Alberta Health Services team, or if we do have someone within Alberta Health Services team, but not necessarily on a feeding team, how do we access that resource? How do we train up our colleagues? I mean, because our mental health therapists don't necessarily understand this work well. Like, I'm not that we're gonna, it's a systems issue that we're not, but we're just talking practically. I'm very, very practically, how do we engage our colleagues in discussions and supporting families? Okay, so do we want to do breakout rooms? We got like 6 minutes left before we finish up. Do we want to kind of end with that and then just not regroup, or is that, I'm okay with either way, if that's, or we can just end here. And anyone of you who want to stay on longer, Justine saying probably good to end, okay. And anyone who wants to stay on longer and feels, you know, more comfortable just asking questions with a smaller group of people drop off, then I'm happy to stay on.
Thank you very much.
You're welcome.
Yes,
Thanks for
thank you.
joining in.
I'm hoping some people stay with some questions.
Yeah, well, we'll just see if anyone wants to hang out. I'd be curious with my Edmonton OT people if how that worked for you. Just to get some feedback, quick feedback if you have a minute or two. Because the Edmonton folks have heard me do this